Welcome back. It's time for us to get into a conversation. And you know, this segment is always exciting because when Dr. Kelvin joins us, there's all reasons to be laughing behind the scenes and everything else. But Dr. Kelvin is here with us, Dr. Kelvin Owusu. And we're going to be talking today about hypertension in pregnancy. Very important conversation for us to have. Dr. Kelvin, good morning.
Morning.
Welcome.
Thank you.
Prostate exam, we're going to do this week.
Definitely. Are you coming with the cameras?
Oh,
yes, because we want to watch some.
No, I don't mind, but I have to discuss with the production team.
Okay.
Yeah, okay.
If we have,
Okay.
availability.
I'll be on standby.
No, but I mean, we would want to watch, package everything. Feel free to edit, and come and show us the rest. I mean, for educational purposes. Dr. Kelvin, you're welcome.
Thank you very much.
I want to see that report.
Wow.
I want to see, and take this as work.
An assignment.
Your promotion depends on
Human interest.
Absolutely, it is human interest issue. But we're looking at hypertension in pregnancy.
Yes,
what is
we are.
hypertension?
Well, I mean, hypertension basically refers to your blood pressure above a certain amount. The cutoff that we all know is 140/90. That's 140 systolic, 90 diastolic. But over the years, we are bringing it down gradually because we realize that complications begin even when your blood pressure crosses 130. So there's a stage 1 hypertension, which is from 130/80 up to the 140/90. You may not necessarily be on medication for that level, but you need to be cautious because you can still develop complications as a result of that blood pressure going beyond that limit. So that's basically hypertension.
Okay.
And when this happens in pregnancy, it's called hypertension in pregnancy, keeping it simple.
But what would cause this?
So before we go to what causes, there are about 4 different types. The fact that your blood pressure is high in pregnancy, or should I say not all hypertension is hypertension when it comes to pregnancy. There are 4 different types. There's one we call gestational hypertension, which means that you were normal. Your blood pressure was normal before pregnancy. And then after you cross 20 weeks, we noticed that your blood pressure was above the limits I've described earlier. In which case, it's assumed that it's the pregnancy that has resulted in the blood pressure going up. But these people don't have any organ complication, any organ damage. So it's purely blood pressure that has gone up. Then there's another group of people who are already hypertensive. So they are chronic hypertensives and then they are pregnant. So before they were pregnant, they're already hypertensive, or this hypertension was diagnosed before 20 weeks. So basically the important landmark is the 20-week mark. And so before 20 weeks, if you are diagnosed as hypertensive, then it's assumed that you already had a hypertension, we just didn't know. That is why we are discovering it before 20 weeks. And so you are a chronic hypertensive who also happens to be pregnant. Then there's something called pre-eclampsia. And pre-eclampsia is where there's still hypertension in pregnancy diagnosed after 20 weeks, but this time there is associated organ damage, which is typically noticed as protein in the urine. So anybody who has gone for antenatal will notice that they are always particular. If you go to antenatal and you don't bring your urine along, wahala for you. So because it is very common, and I will come to that shortly. And the 4th one is a chronic hypertensive who became pregnant and then developed superimposed pre-eclampsia.
That is deadly.
Exactly. So these are the 4 types of hypertension that can occur during pregnancy. And so I mentioned that the in Ghana or in Africa, because of our skin, the black race is already predisposed to hypertension. Now, even if there was no pregnancy in the discussion, because you are black, your risk of hypertension is higher than the general population. And so obviously we are in Ghana, so generally we are all black. And so that's why if you go to antenatal and you don't carry your urine, it's a big deal.
What makes us predisposed to hypertension?
I mean, it's the genes. Everybody has their issues. I mean, the Caucasians have their own issues, autoimmune issues especially. The Mediterraneans have their issue. And we as the blacks, our issue is hypertension, and diabetes, there's poverty and other things that we are not talking about that today.
So what is the commonest, of all the 4 that you've explained to us here in Ghana, what is the commonest?
It's a bit difficult to say. You see, because the thing is, there's a crisscross of all these things. So we don't necessarily, apart from the chronic hypertensive, like somebody who was already hypertensive and became pregnant, where we need extra. If you are a known hypertensive before you got pregnant, we need extra precautions. So we treat you extra special. Apart from that group, the rest of them all we sort of discover them as we go along. And there's a possibility of you from gestational hypertension becoming pre-eclampsia. So we don't necessarily separate them into gestational hypertension or pre-eclampsia because all of them have similar progression, and so we treat them all similarly. Apart from the chronic hypertension, like I mentioned, because they would need intervention even before the baby is fully formed.
Yeah.
You see, because I guess we just dovetail into the treatment because pregnancy itself, we call it a physiological pathology, because the body is, I think I explained earlier on that it is a parasite. The developing baby is a parasite for all intents and purposes. It is feeding on the mother. So the body has to put in measures to prevent the immune system of the mother from destroying that parasite. Because once a malaria parasite enters your bloodstream, the immune system is activated to fight it. It's the same response that the immune system would have towards the baby. Okay. So there needs to be mechanisms in place to shield the baby from the attack. And some of these mechanisms actually are part of the predisposition factors for the development of hypertension. Apart from being black, there are other things. But of course, there are also other predisposing factors. One, which is something that is very critical in this our country, is the age of the mother. Extremes of age. So any woman who becomes pregnant before the age of 20 is at high risk of developing hypertension in pregnancy, very, very high. And also anybody who becomes pregnant after 40, especially if it is your first pregnancy, the risk is higher. The reason why the first pregnancy is significant is because we don't know your history.
Okay.
So we don't know how you behave when you're pregnant. And being 40 already, you are at risk of several other things. Yeah. And so we don't know how your body will behave. And so the hypertension also tends to hide in the background there. Yeah. So age of mother is very important. Then your past history, like I mentioned, if you've developed pregnancy-induced hypertension in the past, the likelihood that you're going to develop it again is higher than the general population. But at least we know. So then we're able to now anticipate and then put measures in place. Yeah. If you have other conditions, diabetes especially, or if you have kidney disease or any other disease that predisposes you to hypertension, the chance of you developing it in pregnancy is also higher. I mean, there are other things, but these are the big ones, And so it's a real issue that we face in Ghana all the time. And the complications are also very, very, very real. I'm stressing on the very. Yeah. You see, because attendance at antenatal is so in the first trimester, second trimester is significantly high, but then it drops as people are approaching delivery, And so we have a lot of people that end up losing their pregnancy, which is part of the complications of hypertension in pregnancy, because the development of hypertension will limit how much nutrition the baby is going to get. If we don't get the blood pressure under control, it's going to limit how much nutrition the baby is going to get, because placenta blood supply is going to be compromised. Yeah. Once the placenta blood supply is compromised, it means that the blood going to the baby is also compromised. So women who develop hypertension in pregnancy are at risk of losing that pregnancy. If they don't lose the pregnancy and they're able to go through delivery, they tend to have preterm labor and premature babies. And all the related complications of prematurity are real, such as a poor development of the lungs. The baby comes out and cannot breathe on their own. It's not easy, And then if they don't develop prematurity, they tend to have intrauterine growth restriction. The baby, because the blood supply to the baby is limited, the babies tend to be small. And again, there's a complication of low birth weight, which predisposes them to early neonatal death and all the related activities. So basically, all I'm saying is that if you are pregnant, you need the antenatal care. It's not optional. It's not like a suggestion. Or if you can go for antenatal. It's not a suggestion. Yeah. It is a critical part. It's like you sign a contract. You decide to get pregnant. It's a contract you have signed to attend antenatal. It's a must. Yeah. You must have at least 4 antenatal visits before you deliver. Yeah. And that's assuming everything is normal. So you go once once every trimester, and then you go for a bonus one to make sure everything is fine before labor. That's the rule.
No, but doctor, how can I tell that I have hypertension when I'm pregnant? And apart from checking, are there signs that will let you know that this is the situation?
So let me take it from here. When it comes to hypertension, by the time you notice signs, it means that you're in the danger zone. Yes, it's progressed quite far, so we don't actually want to wait for signs.
Yeah.
So that's speaking in general terms about hypertension. That's why it is called a silent killer. It does not give you any notice that I'm here.
Okay.
So you are going about your duty. Case in point, somebody walking around and then just drops dead. Oh, nothing here. But you go and do a postmortem and you realize that his heart is about 3 times the size of a normal heart, which is one of the complications of hypertension. You see. So there are usually no signs and symptoms. However, should you develop signs, some of the commonest signs that you develop, especially in pregnancy, is headache. Headache, and then blurred vision is very common. So if you are pregnant, especially approaching the latter parts of pregnancy, but it can happen at any point in pregnancy. If you notice severe headache associated with blurred vision, don't even waste time taking anything. Report at the hospital immediately.
So I have a question on this. So because usually when you are pregnant, you know, headaches and stuff like that are kind of your friend, you know, right through. How do you differentiate between these headaches? You've mentioned, will a hypertension headache always come with a blurred vision?
Well, I mean, so here's the thing. Now you are pregnant, right?
Yeah.
So basically what you knew as normal is in the past.
Yeah.
It's dead and gone. Everything that's happening to you right now is different. So never assume that it is a normal headache I was experiencing. So that's the first thing.
Okay.
Report to hospital, or if you have a BP machine, check your BP, because usually that's the only way you can tell. So you check the BP, and if the BP is high and it's associated with the headache, then you know that this is approaching pre-eclampsia. And it's even complicated if once you notice the blood vision, whatever you are doing, this is like stop, drop, and roll.
Yeah.
Stop, get to the hospital immediately. It's because if we don't do anything about it, the next thing you are going to notice is a seizure. Yes, and common English is convulsion. That's what I'm talking about. So pre-eclampsia progresses to eclampsia. You know, once there's a pre, means that there's something. It is in preparation for something. So eclampsia basically is a seizure that is occasioned by the raised blood pressure and then the complications, the organ end organ damage that is ongoing. That's what results in the seizure. We don't want to get there at all. So if you notice headache, at least report also. Let them clear you of any other thing. It could be malaria. I mean, it could be anything else, but we don't know. Because we don't work with assumptions when it comes to pregnancy. We want to make sure, you see, because if there's a maternal mortality or a maternal fetal mortality, it's a big deal. I mean, people outside the health fraternity may not appreciate this, but if there's a maternal mortality, it is a big deal in our setting. I mean, people there's a whole panel that is set up. You have to come and explain why this happened.
In every hospital?
Yes. But
really?
Yes, but you see, here's the thing. There are 3 levels of delays, you see, and only one of those levels is in the hospital, you know. So if if 2 of those delays are happening outside the hospital, that could be the reason why maternal mortality is so high. But once the person actually gets into the hospital and there's a maternal mortality, there's a whole panel that said they have to defend it, you know. And so it's a big deal. So we don't want it to happen at all. So that's why it's important that you report and then get at least be clear in your mind that this is not hypertension, it's just malaria. Let me just get my malaria treatment. It's very, very important. But ultimately, the baby also is affected by the hypertension. Like I mentioned, the baby is born either preterm, low birth weight. All these have implications, you know. And it looks every time I come here, I mention how sometimes babies children are not performing well in school, and we blame them when indeed it is our fault. So we really need to take some of these things seriously, so that we can get children who can at least participate in the things that are happening around them, you know, to the highest level.
Right. So now I have hypertension whilst I'm pregnant. What next?
So again, hypertension in pregnancy is treated differently from hypertension outside of pregnancy. So there might be a need to change the medication. Assuming you are hypertensive already, you can't just continue taking your medications. But no, let me back it up a bit. If you are hypertensive already and you are trying to get pregnant, first of all, you need to be attended to before you even get pregnant. Ideally, you need to see your obstetrician gynecologist and have a discussion with him or her about my wishes. I wish to get pregnant. I mean, I wish to carry a baby, but I'm hypertensive. What should I do? Because there are medications that are not good for to be taken during pregnancy, and there are those that can be taken during pregnancy. So it is important to start at that level, so that you are, if there's a need to switch the medication, it is switched from then. Don't even wait to get pregnant, you know. But assuming you discover that you are pregnant and you're already hypertensive, you need to report at the hospital immediately, so that appropriate interventions can be put in place, and then the right medication can be started. The aim is to keep the BP as normal as possible. But you have to remember that it is the medication that's going to keep the medication normal. So it is it's not advisable to skip your medication when you are pregnant. You see, because the development of the hypertension leading to pre-eclampsia, eclampsia can happen in a flash. So you don't even want to put yourself at risk at all. So you have to go through the antenatal process. They will check everything, your liver, all the necessary checks will be done, because like I mentioned, end organ damage is also real.
Yeah.
And already, because your system has been suppressed for the baby, it can that's part of the reason why it can progress even much faster than in the general population. You know, one of the things we don't want to happen ever is something called HELP syndrome, which is a further complication of this hypertension pre-eclampsia discussion. Basically, it's a syndrome where your red cells are breaking apart. We call it hemolysis. Your liver is being damaged, so you have elevated liver enzymes. And then on top of all this wahala, your platelets too are low, which means that at that point, should you even go to labor, the probability of you bleeding to death is very, very significant, because platelets are the first line to stop bleeding. So the platelets are already low. What is going to stop the bleeding? So we don't want to get there at all. So it's something that we need to prevent as much as possible. That's why you need to report to hospital. So I mentioned the 3 delays. One of the first delays is actually from the patient, because the decision to even go to the hospital, you see, they'll look at all other things, you know, money, you know, car, all those things are part of the thing, so that by the time they arrive at the hospital, it might be too late to do anything. You see, so that's why the three delays, part of the fixing of the 3 delays is also, of course, government, you know, because if the systems are not set, you know, no ambulance, etc., it causes problems. But eventually, I guess that's why we are here. So if you notice some of these things, if you've checked your blood pressure and it's high, don't sit down and don't adopt a wait and see. Report and have it attended to immediately.
Wow. I think, I guess my question would be, you know, hypertension in general. If you have, let's say, a monitor at home and you're checking, are you 100% safe doing that if your readings don't cross the prescribed lines? Are you 100% safe?
So the reason why I'm smiling is that this question is actually a very big question. First of all, how do we know that the monitor you are using is a standardized monitor? So that's the first thing. So the readings you are getting, is it actually correct? We don't know yet. So let me just give you a basic approach to how you can standardize your own thing, even though it's not the official. So basically, carry your machine to a hospital. Because we are assuming that the hospital machine is standardized. So that's that. Let me drop that caveat. So take it to the hospital, check the BP, and then use the hospital monitor to also check the BP. And then if the readings are about the same, then you know that what you have is okay. You know. So yes, if you check the blood pressure, assuming you know what the limits are, and you check and it's within the limits, then you're okay, basically. Because once you're hypertensive, obviously you're going to see something. Having said that, even though there's a general a Bell's curve where everybody is supposed to fit, so that's how come we know that the normal is usually about 120/80. There are people on either side of the Bell's curve. Some people might actually have a normal of 90/60. So if your normal is, let's say, 90/60, because you have a monitor, you have realized that my normal is 90/60, which then means that by the time you actually reach 120 or 130,
then yours is actually going high.
Exactly. So then you don't use the general normal as 120. So actually, I advise everybody to actually have a monitor at home so that you can actually know your normal, which is also part of the reason why we advise that everybody should actually be doing a baseline wellness, you know, studies, you know. So every year you should actually go and check your kidney, check your liver, check your eyes. Once you have a baseline, then when there's a shift from the normal, we can pick it easy because it is peculiar to you. You know, but where everybody assumes that the normal is 120, so once I'm 120, I'm fine.
Because it's in a textbook.
You could be 120 and actually be walking around with hypertension, you know, because your normal is maybe 80/50, you know. So we need to know our normals.
Well, it's good to have these kind of conversations because we learn every day.
I'm bringing my machine along when I come for the prostate exam.
You should.
I need to standardize.
Because I'll come and see you.
You should.
Yeah. You know.
But let me just chip this in. So there's a new there's a wrist monitor, which the studies are still ongoing as to whether it is as accurate as it's claimed to be. So I don't actually advise my people to use the wrist monitor, you know, because the studies are still not too clear. So it's better you use the mid-arm monitor for now. Unless, of course, you have access to the data that suggests that what the specific one you are using is as accurate as it's claimed to be.
Okay, all right.
All right. So we'll see you on the flip side. Thank you very much, Dr. Kelvin.
Definitely.
Right. This is Breakfast Daily. We'll be right back.